Well, it really is a great pleasure to be here, and so many thanks to John, Nona, Claire, and all at MPN Voice that put on this meeting. Indeed, these are really amazing events. You know, they celebrate teamwork, they celebrate community, and I hope that it helps to impart everyone with both a sense of energy and a sense of hope for the future to see how many different individuals are working on your behalf, how many different pieces of research, of clinical care are being woven together to try to make a difference. Now, clearly, MPN community is a very special place because of the teamwork involved. And a key part of that teamwork is really the input of yourselves. Indeed, the voice of the patient, both in terms of our goals, as we try to move the field forward, are incredibly important. So I almost lament I don't have a good Texas picture here to share. I'll have to insert that. Although I did find on Seville Row, I did find some Texas cufflinks that I was able to pick up for home. But excited about my new venue and opportunities. Although at a different venue, my focus on MPN patients clearly is only further expanded. So Claire had asked me to speak on the concept of looking forward in MPNs. And looking forward, I think, includes a variety of different parts. There was a great question in today's morning session, where do we really stand 5 years from now? And I think that includes many parts that will really weave into this conversation and really the partnership. The first is really the issue of individualized care. So what does that mean? In medicine, that has become somewhat of a surrogate term for looking at genetic changes and seeing how those genetic changes have implications in terms of treatment. JAK2, CALR, MPL, ASXL1, and that list will only continue to grow. However, what we're learning is that individualized care starts with the different genetic changes, but it does not end there. It has to do with the rest of your health. It has to do with your choices. It has to do with your level of fitness, as well as many features about the disease. Now, indeed, a theme of today is really seeing how do we evaluate you as an individual in terms of a disease. With an MPN, it includes many things. In the past, it clearly was issues of thrombosis. Professor Barbui covered that very nicely. That still is a concern that we have, but it's not the only concern. There are implications in terms of the cytopenias. There are implications in terms of the wonderful talk you just heard from Professor Wilkins regarding the bone marrow. Now, what does the bone marrow tell us about your disease? There is the impact of the spleen. My group has been very instrumental in looking at symptoms and what do symptoms tell us about the disease. Additionally, we have learned that the rest of your health is an incredibly important part of making that assessment. Now, there are a variety of things that we have learned over the recent past, including trying to quantify the burden of having an MPN. And one of those burdens can be impact on employment. Can that be leaving work early? Can that be retirement? Can that be being medically disabled from the disease? It's an important part, as well as if we see favorable implications of therapy, perhaps it can reverse a negative status on employment. Now, we've been involved with studies, this is just the P-Vera data, but we went specifically to patients and asked in a partnership way, what are your main goals as we talk about MPN treatments? And it was pretty clear that for patients, their main goal is to try to avoid progression of the disease. Now, for many, you have not necessarily had that conversation with your physicians. I would like to avoid progression of my disease. Part of the limit, as you've heard from today's talks, is that with many of our therapies, we do not know whether they will limit progression of the disease, but that still remains one key goal. Now, symptoms. Symptoms with the disease have taught us many things. One, it has showed us that the burden of having an MPN can be significant. Two, we know that issues of fatigue are very common. Three, we know that certain symptoms can be associated with changes in the disease or progression. And 4, and this is how my colleagues and I have advocated to others in our field, how do we assess symptoms in the disease in parallel with other key endpoints in terms of why we treat the disease? Avoiding progression, improving blood counts, shrinking the spleen, and improving symptoms. It's not necessarily just about improving one of those issues. Ideally, we try to tackle them all. Now, symptoms in the disease are not just random, and we have had a lot of interest studying what is the reason people have these symptoms, and what does it tell us about the disease. Indeed, there are 2 schools of thought that each have an implication. One is that symptoms can be in part due to the anxiety or uncertainty related with the disease. I have this disease. I do not know what my health is going to be 5 years from now, 10 years from now. That creates stress. That creates symptoms. 2, that the disease is associated with inflammation and increases in protein called cytokines, and these 2 can be drivers of symptoms. Indeed, there probably are components of both. In, again, a partnership with the MPN community, one of a very vocal MPN advocate, wonderful gentleman, Zen Senyak from the US, he went to me and my group and he said, I suspect, dealing with many patients online, that issues of anxiety and depression are real. And that uncertainty for some individuals is very difficult to deal with, and that I think some of my fellow patients are depressed, and it's not being noticed. So we work with psychiatrists and psychologists to do a series of questionnaires to try to quantify that. We were able to get data from 1,800 patients, including patients here from the UK, and identified that the likelihood, based on standard questionnaires, of depression, anxiety, stress, or grief are very real, and they are much higher than the general population. And it's important that we know that this can be a factor, because these things too can have treatment. There are ways to help these things, but we have to know that they're there. And sometimes our healthcare team has to involve not just a hematologist, but others to help us overcome that uncertainty. As much as Claire or I or others would like to say, you don't have to worry about the future, we know that unfortunately that's not true. So as much as we would try to help things for the future, that uncertainty we can't take away. And indeed, symptoms can be tied with untreated depression and mood problems. Now, as we look toward the future, I would say that it includes 2 parts. 1, how do we better utilize the treatments we have? 2, what are new treatments that we can develop? So 1, in terms of treatments that we have, there are key questions that are at the current time. What is our very best treatment initially for ET? How do we prevent disease progression? Is there a role for JAK inhibition in ET? A key question in ET and PV has been, what is the role of interferon, or long-acting interferon called Pegasus? I was involved, as well as many of our colleagues here today, in a randomized study of interferon versus hydroxyurea for patients with high-risk ET and P-Vera. And what we were able to demonstrate was that through 1 year in time, the 2 drugs were relatively equivalent. They helped to decrease the rate of blood clots at a similar rate. They had a similar impact on fibrosis. They had a similar impact on symptoms. Now, in one way, that is very beneficial information. It was the first time a large randomized study had proved interferon was clearly beneficial. Was it better than Hydrea? I don't think we can answer that after 1 year on such a study. It may well be an issue that there is no difference. That is one possibility. The second possibility is we may not see a difference in terms of the impact for longer periods of time. It may take 5 years. It may take 10 years to see a difference between those 2 treatments. In polycythemia vera, the same question exists. What should be the initial treatment? How do we prevent disease progression? And should we be using JAK inhibition earlier in the course of the disease? Here in a parallel study, this is from a similar long-acting interferon. Stefan mentioned earlier today This drug may well become approved in Europe at some point in the near future. None of us ever really know whether that will be the case with particular trials, but this, I think, has a good chance. And this was a long-acting pegylated interferon from Austria compared to hydroxyurea in polycythemia vera. This study, called the PROUD-PV study, demonstrated, again, at 1 year, interferon and hydroxyurea, or hydroxycarbamide, as it is said here in the UK, really were equivalent. So again, 2 different studies, 2 different formulations of interferon, for me, confirms pretty solidly interferon and hydroxyurea are probably at least interchangeable through that first year of treatment. Now, there are pluses and minuses to each of these that are nuanced, but it shows us that both of these are a consideration. Now, they are studying individuals on that trial over longer periods of time to see, are we able to see differences that are meaningful? Is that on a genetic basis or other? Still premature to say that one drug is clearly better than the other. Looked at a different way, these data do support that it is not wrong to be on one of these drugs versus the other. Now, what about ruxolitinib? Well, ruxolitinib has a role in polycythemia vera. Its approval has been on the basis of people with more difficult polycythemia vera, those that had failed hydroxyurea, those that still needed phlebotomies, and those that had splenomegaly. And compared to best alternative therapy, it showed that ruxolitinib was better for controlling the blood counts, it was better for reducing an enlarged spleen, better for controlling symptoms, and less blood clots. So all of that pretty favorable. Similarly, there was a subsequent study shown in another group of patients with P. vera that had the other features. They had failed hydroxyurea, they needed phlebotomies, but they did not have splenomegaly, that they too benefited from ruxolitinib versus best alternative therapy. Now, what about new therapies? New therapies are many things that are interesting. Again, where new therapies fit for a particular individual is usually if the treatments that we have currently are not working well. One such trial is for a new type of agent called a nutlin inhibitor that looks to shut down one of the overly active pathways that's overly active in patients with P. vera. This early study has been favorable and is being tested in a larger trial in the US and likely here in the UK shortly. Next, there are several JAK inhibitors that are still being tested. One, fedratinib, that had been tested in the recent past, may resurface as a drug that can help shrink the spleen or improve symptoms. 2, the drug pacritinib, that's similarly a JAK inhibitor that may be slightly different in that it can be used in individuals with very advanced disease or low platelets. It was presented at the American Society of Hematology earlier this year that this drug was beneficial for shrinking the spleen as well as improving symptoms, and they found issues regarding the dosing of the drug that may find a path for that drug to become an option in the future. A cousin drug of this, momelotinib, was tested and presented fairly recently by myself and my colleagues. This would be for newly diagnosed patients with myelofibrosis with anemia, comparing momelotinib versus ruxolitinib as the initial treatment for myelofibrosis. So 1, we assess how helpful is the drug by seeing does it shrink the spleen? And the answer was yes, and at a similar rate to ruxolitinib. 2, how does it compare in terms of improving the symptoms you have with the disease? And it showed, in fact, that the improvement was probably not as favorable as that of ruxolitinib. So this single point was sufficient for the FDA to say that this drug was not as good as ruxolitinib for an initial treatment in myelofibrosis. Doesn't mean that it can't help certain people. Doesn't mean that it may not help in some other situation, but at least as new treatment was not as good. Although it did perhaps have some benefits in terms of causing less anemia or drop in the platelets. There's other drugs in development. One a cousin of this drug, sotatercept, called luspatercept, that's going to be tested here in the UK shortly in a trial. You'll hear about that later this afternoon. But sotatercept, again, a drug helping to promote the creation of red blood cells and helpful in people with MF, with anemia. So finally, non-pharmacologic approaches. I have a group that is determined to leave no stone unturned to see how we can help patients with MPNs feel better. And this includes clearly robustly looking at new medicines. But we do see that there are individuals who are on medicines, and the medicines are controlling their counts or controlling their spleen, but they still don't feel great. They still have fatigue, or they still have some night sweats, or they still have some pruritus, or what have you. So we've been very interested to see, okay, well, what else can we do in addition to try to help you feel better? Indeed, sometimes just giving you more pills is not sufficient to really have you feel as well as you can. Indeed, it really takes a partnership to try to help you to be in the best health that you can. So we've been looking at a variety of different interventions in parallel. And the first that I would highlight is yoga. So first, people will look at me and go, this guy does not know how to do yoga. Why is Ruben Mesa talking about yoga? And please, no pictures of Ruben in yoga pants. So fortunately, I have very smart friends who are experts in yoga, and indeed, we started with the concept, okay, well, yoga can be helpful. Yoga's been helpful in breast cancer patients. It's been helpful for all sorts of folks. But how can we take yoga and make it a resource for MPN patients? Something they can do at home, something that's specific for them. So we worked with an online company, Udaya, that their job is to teach people how to do yoga at home, even if you've never done yoga ever. Now, you could do it at home. You can wear those ridiculous yoga pants. Nobody has to see you. You can kind of take it at your own pace. So we taught them about MPNs over 2 to 3 days, and they created the first disease-specific yoga modules ever created. So there's MPN yoga, but there's no other disease-specific yoga that exists for any disease. So the MPN patients clearly leading the way. So we had done one study and demonstrated that it was helpful. You could do it, patients could follow it, it was safe, they could follow the modules. So we wanted to do the second study. Okay, can we measure other things to try to prove the benefits? So with this was a 12-week study. Patients were randomized to 2 groups, yoga or a waitlist control, guiding for 60 minutes of online yoga. And people in the control were on a wait list, and then after the 12 weeks would go on to the study. What we identified is that there was significant improvement in terms of how people felt and clear improvement in terms of depression by objective markers. We were able to demonstrate that we can obtain blood samples from a national US-based study sent to central labs, and we were able to measure improvements in inflammatory markers such as tumor necrosis factor alpha. Here just showing differences in terms of depression, and then we see differences in depression, anxiety, pain intensity, improvements in issues with intimacy, sleep, and others. So this was a second feasibility study, and now we are embarking on a large phase 3 study that will probably have about 400 patients with MPNs. The next is really a cognitive intervention, saying, okay, I've got this disease, how do I wrap my head around it? How do I put this into my frame of reference in a way to be able to manage that uncertainty? So there's a resource that's been developed that's called ACT therapy, and Nona and I were speaking about this yesterday with some of her expertise, that's been helpful in a variety of different conditions. And indeed, this study is ongoing, looking at modules that, again, will be online. First, it's face-to-face, but then online for MPN patients. The final is really regarding nutrition. Now, when it comes to nutrition, I have little doubt that nutrition can have an impact in terms of how we feel. But trying to study the impact of nutrition is complex. If we want to decrease inflammation, which we know is present in MPNs, should we use an anti-inflammatory diet? Which anti-inflammatory diet? How do I convey to others what that diet should be? Can they follow what that diet is? Will they adhere to that diet? If they do adhere to that diet, will they have improvements in symptoms or other difficulties? So this is ongoing as a collaborative effort with our colleagues from the University of California at Irvine. So I'd conclude by saying that individualized care is really evolving for MPNs. That's a key part of the future. We have a clear evolving of the risk burden and the role of current therapies. I think we are going to refine how to use our current therapies as well as how we develop new therapies. And finally, we'd like to think clearly these efforts are a very collaborative effort between many friends and colleagues, and it's a collaborative effort between my current center, my continued friends and colleagues at Mayo Clinic, the Arizona State University, and the University of California at Irvine. Thank you.